The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Good afternoon. Thank you for joining us for this afternoon's QTECH meeting for March. We will be getting started in just a couple minutes. Thank you. Hello, everyone. Good afternoon. Thank you for joining us for March's QTECH committee meeting. We'll be getting started in just a couple more minutes. Thank you. So today we'll be participating in a live word cloud activity as part of the presentation. So we'll be asking, what patient engagement tools does your health center currently use? So on the next screen, you're going to see the question here. So in order to participate using Poll Everywhere, you will need to text the message QTECH, QTECH, to the phone number 22333.
Hello, everyone. Can you hear me?
Yes, we can, Quasi.
Okay, awesome. Thank you.
You're welcome. Right. And we can see your webcam perfectly. So good afternoon, everyone. Thank you for joining us for QTECH committee this afternoon. We're going to go ahead and just get started in the interest of time because we are a couple minutes after the top of the hour. So with that, let's go ahead and advance to the next slide. So thank you again for joining. For this section, I just wanted to cover some key updates in terms of logistics to participate in the session for this afternoon. So in order to participate, you are joining this webinar in listen-only mode. So for that reason, you have to make sure that you are able to pin yourself into the phone call for this afternoon session, so you're able to participate verbally and raise your hand if you'd like to participate using that way. In addition to that, we are also making sure that you can use the questions panel during the session. So during the webinar, any questions that you may have that come up during the process, feel free to use those as well, and our team will be monitoring those different items within the chat and Q&A box. And then, of course, as all of our other previous QTECH committee meetings, these sessions are being recorded so that you are able to revisit them at another point in time. And again, thank you for participating. So welcome, everyone. We're going to go ahead and just take a quick look at the agenda for today. So we're going to start out first with our welcome and introductions, which we just currently did with you all. And then we're going to go over again the word cloud activity that we're going to have. Being a part of that word cloud is going to help within the remainder of the webinar today for this afternoon, as we're going to have some special guests with us, one of which is from the High Tech Center. We have Dr. Nathan Botts, who will be talking to us today about a patient engagement learning collaborative. So we're excited to launch session 1 of that series and have him join us for the next 3 remaining QTECH sessions to learn a little bit more about patient engagement tools and how to set up those tools for success and evaluate them within your health center. In addition to that, we also have another special guest from our health center. So we have Mr. King, who's joining with us from Banyan Health Systems, and he'll be telling us more about their telehealth monitoring kits and how they've implemented those. Then we'll round out the remainder of the agenda with UES ECQM updates. We'll hear from Harut Kasai, who will give us some key updates related to those items. And then we will also have some QTECH strategic planning review and take a look at those different items. And then we will also have a plug within our agenda with Kwesi, who will talk to us more today on how to prepare for STD Awareness Month, which is taking place in April. Okay, so as I mentioned, now is the time to take out your phone so that you are able to participate in our word cloud activity today. So in order to do that, you're going to need to take out your smartphone and open up your messages. And in the to line, you want to put the phone number listed here on the slide, so 22333. And then in the message box, you want to include QTECH. As soon as you do that, you should receive a confirmation message that states you are within the QTECH realm of things, and you are able to participate within the live word cloud and other polling activities that we have designed for today's session. So for today's word cloud activity, we're asking everyone to answer, what patient engagement tools do you use currently at your health center? I know that a couple folks had put some options in the marketing section. So as those are coming in, we're going to activate them. Perfect. So let's take a look at the word cloud as all the different options are coming in. So it looks like a lot of folks are using Care Message, Reja, Solution Reach, text messages, patient portal, Get Well. That's another really important one too. I saw someone that said phone calls, just manual calling on the patient, checking in on them, patient portal, Health Assist. So that's fantastic. Reja, Blue Stream is another new option I see here listed. That's fantastic. Thank you so much for participating in this. And I think that this is a great primer for us today as we kick off our patient engagement collaborative learning series with the HITECH Center with Dr. Botts, who's going to help to provide some additional insight to us all within the next couple QTECH meetings on how we can help improve our current electronic patient engagement process at the health center, evaluate the tools as we saw there's so many that are used on a daily basis or just within our health centers to engage patients in healthcare. So without further ado, I'd like to pass it to Dr. Botts to kick off for today's Learning Collaborative session number 1 on patient engagement.
Okay, can everybody hear me and see me?
Yes.
All right, great. Well, thank you, Stephanie, and thanks to your whole team for inviting me and inviting the HITECH Center. So the HITECH Center, hopefully many of you are familiar with us. HITECH stands for Health Information Technology, Evaluation, and Quality. And as noted, we're kicking off this learning collaborative with the Health Choice Network around patient engagement, specifically electronic patient engagement. And so this is our first session of that collaborative. And so let me just say that thanks so much for being here and all the work that you guys do. I know you bring a lot of experience, and obviously from the word cloud, a lot of you are working with different tools there. So it's great. And so hopefully this will be interactive, meaning please chat in your comments, your own experiences, your questions, and I'll try to answer those as much as possible. But again, I'm always here to learn from you all as well. So thanks. My name is Nathan Botts. Next slide, please. Actually, so I am Nathan Botts. I work for HITECH. HITECH is a HRSA-funded NTAP that provides technical assistance in training across a number of topic areas. The key is our training is very specific to health IT. And so we focus, say, an example for patient engagement, we're talking about the IT or electronic aspect of patient engagement. Of course, that's a bigger, broader topic. But we provide assistance for free to health centers and health center controlled networks and PCAs across these different domains here, and I won't read through them. All these are available on the HITECH Center site. And so this is just one domain of TA and training that we provide here. And so by all means, please go check out hitechcenter.org. And I work with WestStat. So HITECH Center is a collaboration partnership between JSI and WestStat, and so I'm a senior study director with WestStat, who does a lot of federal contracting in the healthcare space. Next slide, please. So in this first session, what we're trying to do is just generally set the stage around electronic patient engagement and activation, talk about our opportunities and barriers related to the use of these particular tools within the populations that we serve, and then a general discussion around different methods, measures, and evaluation tools that can be used to better understand where our patients sit within those concepts. Next slide, please. So we hopefully through this session, we'll just generally increase awareness of some of the specifics around patient activation and engagement. I think we all know why it's important, whether it's for the patients we serve or for ourselves, being better managers of our own care and more activated in it. And but there's ways in which to tell where we kind of sit on the curve of activation, and likewise with our patients. And so we're always trying to push for further and further activation engagement, because the more we understand the patient's needs and unique circumstances and hopes and dreams, the better then we're able to provide services to them and help them with their health goals. And these tools that are available to us, there's a number of them. They, whether electronic or analog, paper-based type tools, or discussions, things like that. All of these serve a purpose, and all of these kind of help triangulate on the needs of our patients and because some, of course, will have different needs than others. All right, next slide, please. So what I bring to this, so that picture there is actually, it's always crazy to me, but it's about 14 years old now. When I was working through my graduate studies, I was at the time working for the Migrant Education Program as their technology director. And I was working closely with the health director in providing health information resources for migrants. And through that effort and some funding received from the Blue Shield Foundation, put together a grant to create this personal health record system. This was in California. It was bilingual between English and Spanish. And the identification was that, especially for migrant populations, they moved around a lot, and them maintaining their health records, especially when we're talking about moms with kids and things like that, that was a critical need. Now this was early on. Many of the FQHCs that I was working with in Los Angeles and up in Kern County, the Central Valley, did not yet have electronic health record systems implemented. And so, all of this was a huge learning lesson. The focus really wasn't on the technology. I mean, that was an aspect of it, but it was about this engagement piece. It was about working with patients, who were working through many challenges, and finding out the unique ways in which we could kind of nudge them in the right direction and increase their level of activation and feelings of engagement in their health. And so, I was doing studies of that at the time, and so we did a lot of surveys and interviews talking about people's feelings about their ability to manage their health care. And so a lot of these pieces that I'll be pulling out here are based on some of that work. But then, a lot has happened since then. And so, we continually are trying to learn from all of you and your experiences, and are always asking, what are some of the big challenges that people are running into? What do patients want? And so, we continue to try to build on these findings. All right, next slide, please. All right, so let's talk about electronic patient engagement. Next slide. So to add to our polls, we're going to ask you what best describes your role as it relates to interests in electronic patient engagement. Okay, and so please, you'll be able to check off if you might not fit into any one of these buckets specifically, but try to put yourself into the best bucket that relates to you. And I believe, yes, you'll be answering A, B, C, D, E, or F in relation to their location. Great. It's looking like we have a pretty good mix across staff. That's great. Obviously, in order for both patient engagement strategies and the use of electronic patient engagement tools, it requires buy-in from every level of the health center. And so great that we have a good mix of folks. And when I was working with the health centers and implementing the health ATM system, so that system was, as you saw, the kiosks that we actually put in the front lobby, or depending upon the health center's size and makeup, we were finding places for the kiosk. It provided education tools and ways in which to track their care plan, and we included incentives for moving forward on their care plan goals. Those weren't just health tied; some of them related to, say, paperwork or transportation issues, and so every one of those things crossed broadly across the staff. Okay, thank you so much. Good mix of folks. So patient activation and engagement, they both tie over with one another, of course, but they are essentially two different concepts. And so patient activation is where the patient sits in their ownership, I would say, and that ownership of their own health, has to do with their knowledge around it, and education, their abilities, whether physical or mental, and their general willingness or interests in engaging in their care and becoming more proactive about it. And then patient engagement in general, is probably the umbrella that encompasses this activation part, but then is a little broader in terms of the different aspects of both activation and application within their health and their healthcare system and their healthcare providers. And so activation is where then, we're hoping to, push them into the high engagement bucket. And obviously, all these things, and I'm sure you guys have seen plenty of the literature around it, come from studies that identify that the more activated, the more engaged we are in our own healthcare, the more the better health outcomes we have, more positive health outcomes. And this gets into a concept called health locus of control. And in general, health locus of control, spans a line that sits between, high internal locus of control and high external locus of control. And in short, if you have an internal locus of control, or on the scale you sit further in the internal, then you're someone who believes you have, your actions, the way you think about your healthcare, has a high impact in affecting the outcomes of your care and your health. Whereas people who are further on the domain of external locus of control, they kind of believe it's out of their, it's fate, or it's the doctor's problem, or it's their home life or something like that, and that it's out of their control. It's these other things, these external factors that are really dictating whether they're healthy or not. And so, similar to what I was saying, is that we generally find that people with a higher internal locus of control, actually have more positive health outcomes. And so we're trying to move the needle. It's not a black or white type of thing. We're just trying to kind of urge people over to greater internal locus of control so that they can feel more empowered. All right, next slide, please. And so this data, these two slides here that I'm going to show you are some examples of then, understanding the nuance of why we want to kind of understand where people sit on the activation scale. And so this came out of the research that we did, and this was approximately 150 patients that we have been working with. Like I said, these were all part of FQHCs in Los Angeles County, California. And so we're, this first question here is asking the patient to respond to, this statement. And this is the acknowledgement of the need for activation. So the statement is, taking an active role in my own healthcare is the most important thing that affects my health. All right. And we see, it's great. We didn't, we weren't sure where we would get with folks, but we see that a majority sit up above there in those first two bars, in which they're agreeing strongly or generally agreeing with that statement. All right. And so we see, upwards of 90% of our respondents, feel as though they are, which is great. I mean, that's a good first step, because then we know, all right, they're folks who feel like they can do something about it. So this is the acknowledgement of the need for activation. All right, next slide, please. And then this is their ability then to to activate. And so this is the personal ability to be activated. And so in this one, in this statement, we say, I have been able to maintain or keep up with lifestyle changes like eating right or exercising. Now, it's not as though there's this huge shift in the response, but hopefully you can see that there is a shift though. Would you please go back to the previous slide, Diana? Yeah, so we have, the understanding that they're, responsible, and then go to the next slide. And then we see the shift, right? We see this shift of, okay, I know it, but I have some difficulties in maintaining it. And that's then where we see how, that's where we bring the tools in. That's where we bring in these electronic patient engagement efforts in order to help them, be more able to increase that level of engagement and activation and maintain their health goals. And so all these tools that we talk about, whether they're patient portals, text messaging strategies, adherence, reminders, appointment reminders, all of these things are little nudges that come from different areas, depending upon, the particular areas that patients need help with in maintaining their goals. All right, next slide. All right, and so now let's talk about, okay, great, we've got these tools. Sounds like they could be a good thing, but of course there's always challenges, and so let's take a look at the opportunities and barriers for them, and always, thinking about our community health center population. And so our next polling question, if you would, are what, and this of course dovetails into that first word cloud that you did, but we're putting in some more just broad categories versus specific products. So what methods of electronic patient engagement are you using with your patients? Use of a patient portal, social networking strategies, text messaging strategies, mobile health app style strategies, and these overlap at times, I know. Other EPE tools, or no, you haven't really leveraged EPE tools yet. So we have some folks using patient portals, text messaging strategies, social networking strategies. Those can be as simple as having a Facebook page for your health center, or something that you tweet out to your patients. Health apps, I know many of the patient portal applications include a health app like MyChart. And so, there can understood if those are crossovers. All right, so obviously, the patient portal has its own kind of specific requirement as it relates to, previously meaningful use and advancing interoperability. And many of our current electronic health record systems, or most of them, come embedded with a patient portal. We've seen some good evolution around patient portal. And then these text messaging strategies, those obviously work really well for our patients, who don't have access to maybe fancy laptops, or they probably have, a cellular phone, but and then it might be a smartphone of sorts, but it might not be, say, a more advanced smartphone. And we certainly know the curve of that, changes as we look up the age curve. And so, but great. Looks like, some real investment in patient portals, personal health record type systems, and text messaging. Text messaging is great because, lots of people do it, and it's a pretty low cost, low infrastructure opportunity. All right, so thank you. Thank you for responding to that poll. Next slide, please. So we've seen some real explicit, positive findings in the use of these tools. We've seen cost avoidance as it relates to missed appointments, things like that, increase in medication adherence, just better overall communication with their care providers, easier ways to get in touch with our patients. I want it. I bet a lot of you like it, and we're finding that our patients do too. That ease of being able to text in a response and confirm appointments versus having to call in, being able to refill prescriptions easily from your phone, all these things save time and save energy, and we all want that. I have found in my own health care, the tools that are used are great. I mean, they allow me to schedule appointments, respond to requests from the doctor, see my lab results, all these things are great. And so, of course, within our community health center population, then we know that they want those tools as well. All of it's a learning curve, of course, but the more we build off of it, the more our patients become activated, engaged in it. And then it also, provides some great ways of increasing security, increasing confidentiality for patients, being able to sometimes not have to talk about it in person, but simply text a response or an email, can feel safer or less embarrassing for people. And so we know there's some real advantage in using some of these electronic patient engagement tools. Next slide, please. Oh, I'm getting close to my time, so I'll move forward a little faster on some of these. And so, it provides us with more autonomy, more empowerment for managing our care. And so each time we try these new things, we get more out of it. These tools come with great, ways in which to embed education into the services that we're receiving, to better visualize our appointments and schedules and provide reminders and track our goals, whether we're trying to decrease our A1C levels or our blood pressure levels. These tools provide great opportunities, and many of them are embedded in medical devices as well. Next slide, please. So of course there's some best practices, and we'll dive in the next series that we do, the next steps that we do in our learning collaborative. We'll talk about some specific best practices in rolling out electronic patient engagement tools. It's not a one size fits all. It's going to be very specific to your organization and what can be supported there, as well as your patient population and their particular makeup. And so there's always going to be limitations. And so having a plan, evaluating the tools, evaluating your needs, and then creating methods in which to evaluate whether you're actually achieving the goals that you want. And if not, where are you running into trouble? Because you might have the best tool in the world, but it's not going to work great for your population if you can't roll it out effectively and get people registered, or maybe you get people logged in once, but you don't seem to get people to return again. And so what's the issue there? And so trying to figure out how to truly leverage these tools, and because it is an investment, is critical. And so we'll walk through those components and next steps of the collaborative. Next slide, please. All right, so there's lots of things that can get in the way of effective adoption, and we've seen it with patient portals, certainly, all sorts of issues there. And so please answer this poll. What are some key barriers that you have experienced when trying to implement electronic patient engagement strategies? Is it patient interest? Some patients just aren't interested in it, right? Is it a cost thing? You just haven't had the money, whether for the infrastructure, the actual IT, service. A lot of this is cloud-based anymore, and so it's not like you have to have an actual appliance, but they're still costly. We've had a lot of literacy issues with our patient portals, slowly growing. Certainly if your main buckets are between English and Spanish, we've got a lot more in there. But we know in a lot of your communities, we have a broad mix of patients coming from all sorts of cultures, and so dealing with language and literacy issues in some of these tools. Literacy is huge. There's health literacy, of course, there's technical literacy. As we say, our older crowd, they haven't used these tools much, and the tools aren't as built for them, right? Just physically using some of those tools, seeing small screens, sometimes just do not support our population. All right, yeah, and so patient interest is one. Why? What's the value to me? And sometimes that takes a lot of education and training, and if we don't have the funding to do that within our health center, that can be its own sticking point. So yeah, yep. Gaining patients' interest, showing how it can be helpful for their care, make things easier on their life. I mean, really always showing them, of course, improving their health care is incredibly important, but we know that even with patients with, comorbidities, chronic conditions, that, still some of these things just seem like they take too much work, and what's the true value to them? So all right, thank you for that response. Next slide, please. And then we have policy-related factors. I'm going to kind of zoom through these, but of course, we can't just pick anything and roll it out. We need to make sure and understand that it's protecting privacy and security as it relates to HIPAA and other regulations and compliance. We have some factors that really encourage our use of these tools, and we need to effectively engage. We need to provide access to records to patients, and so we have these factors that increase requirements for particular tools that we're rolling out. And of course, being reimbursed for the use of these tools is incredibly important. And some of this takes a long time. There are updated CPT codes related to primarily telehealth, but many electronic patient engagement tools can now fall under the telehealth bucket. Some of that depends on your state. And so we do see that there's a number of considerations that have to be thought through policy-wise as well. Next slide. All right, so next is just to look at some of the methods and measures we have for evaluating activation. I'll make this quick. I think I'm at my time part, but next slide, please. So we were talking about the activation piece, and I want to forward Fogg is a behavioral health researcher, and BJ Fogg, and Fogg identified that getting patients or getting people motivated to do behavior modification, whether for health or whatever, ultimately requires three key pieces: motivation, ability, and a trigger. And so this MAT model is kind of that triangulation of the sweet points in which we get someone to hit that next level of activation. Next slide, please. And so we need to educate patients on why they might want to do this, how this is going to help their condition, how this is going to make aspects of their life easier, or aspects of the people they care for easier. And so we figure these ways to motivate patients, if not for care, for other incentives. And then we need to provide them the ability to act on it, right? I showed those two charts in which we saw they knew they needed to do it, but they didn't so much or as much believe they had the ability. And so, that we, like colorectal cancer screening, we saw that, okay, we do our campaigns, we inform people, and then we need to give them the ability for, actually taking care of it, whether it's home screening kits or, establishing the appointment right there at that time. And then the trigger, right? And so again, that trigger might be a campaign, to push on, moving the needle on, lowering A1C, or, moving the needle on increasing screening rates, or moving the needle on increasing or decreasing no-shows. All of these things will be a part of getting that movement on the behavior change needle. All right, next slide. So I've already gone over activation, and a well-known way in which to measure a patient's activation level is by this tool called the patient activation measure. And in general, what the patient activation measure does, and please go to the next slide. in general, I won't read through these, but in general, what the patient activation measure does is try to identify in what big buckets and in what level your patients reside. And so level 1 is, not activated, generally disengaged, fairly overwhelmed with what it takes to care for themselves. And then this goes all the way up to someone who is maintaining their behaviors and really trying to be activated and engaged in their care. And so there's 4 general levels. And so the patient activation measure helps tell where your patient population sits. And the strategies that you use then with particular patients is going to depend on the buckets they sit in. And then this would follow through with the types of tools you would want to adopt or more heavily push. And so, for your really low activated, you might need to do a number of different tools or focus on one just to get them going. And then for your more highly activated, maybe you don't have to do as much and you use them as champions, for your particular projects or cohorts. Maybe you bring them together, to do some peer group activities. And so at any rate, kind of understanding where your cohort sits and in what buckets helps you decide on methods and tools for impacting your population. Next slide. I'm going to go through past this because I'm out of time, but EHealth literacy, of course, is pretty important. And there's this EHealth methods of understanding where people sit in terms of literacy level. We know these are big issues, especially using information-heavy tools. And these assessments do the same as the patient activation measure. Next slide. All right, so that's it for this round. Thanks so much. Please go to the HightechCenter.org website, and we have many tools and resources and ways to get in touch with us. Obviously, we work with the HCM team, and they can send things our way. And again, this is the first session, and I look forward to working with you guys in the next 3 sessions. Thank you.
That was fantastic. Thank you so much, Nathan. So I'm taking a look just really quick at the chat to see if we have any questions, which at this moment I do not see any questions coming through the chat at this time. So what we would like to do now is transition our agenda to our Health Center Spotlight. So we're very excited to have Banyan Health Systems. We have Mr. King from Banyan Health Systems talking to us today about their implementation of a remote telemonitoring toolkit and their involvement in that. So we're really excited to hear about their experience and kind of lessons learned and things they've had through the implementation process. And we're really excited to hear more information in reference to that. So without further ado, Mr. King, please take it away. I hear you, but I cannot, I see you, but I cannot hear you actually. Let's try. You might be double muted. If you're using your phone, there might be an option where.
Unmuted. Now I'm unmuted.
There you go. Perfect. We can hear you perfectly. Thank you so much.
Gotta do a double click. Double. So fortunately, I had only said a couple things, like thank you for having me, and glad that everybody is here today. I'm excited to get a chance to talk to you about the implementation of our virtual monitoring and remote patient monitoring program. Actually, a great presentation with the predecessor, because there are some points that were pointed out in his presentation that we sort of learned the hard way. So if you'll go to the next slide, I'll walk us through the slide I put together as an infographic. So it'll just be this one slide that I'll just walk us through the various spaces on the slide. Banyan Community Health Center, we're a community health center with 3 FQHC locations down in the Miami, Florida area. We're, I would say, mid-sized primary health, initially started out as behavioral health organization. So we are into integrated healthcare. Obviously, just like with everyone else, when COVID hit, we were able to quickly transition to telehealth. However, what we learned rather quickly is that we had a large cohort of population that had barriers to telehealth, whether that was low income, did not have the technology or the equipment, or maybe had a smartphone but did not have high-speed internet or the bandwidth. And then because of the population we serve, we actually learned that we had patients that had cognitive barriers to telehealth. So we actually applied for and were awarded the FCC grant to expand and enhance telehealth. We were awarded $958,000. And that in itself was an interesting process because once we were awarded, we started reaching out to the context of the FCC. And the original intent of this grant was to award community health centers with dollars to buy equipment. So that in itself, I remember saying to one of the representatives there, well, community health centers don't know anything about buying equipment, especially telehealth equipment. So there's an interesting concept, but we may need to come back for a little more assistance with that. So we eventually went out to try to figure out how we would use these dollars to buy equipment, and we partnered with Vivify Health, which is sort of displayed in the top right-hand corner. Vivify Health already had a sort of a put-together packet, a kit that includes a web-enabled tablet, a weight scale, a blood pressure monitor, a thermometer, and a pulse oximeter. In addition to that, pointed out in the bottom left-hand corner in the information section, and Vivify Health has more than 200 what they call pathways, or basically surveys that are active that can be asked to the patient on a daily, weekly basis. So we started out with 7, that being just a standard virtual visit with biometrics pathway, COVID pathway, hypertension, depression, anxiety, substance use, and then we recently added the diabetes. So we took on the grant and we developed what we called our intensive telehealth unit. I'm a registered nurse with an ICU background, so I thought intensive care unit, intensive telehealth unit, and it stuck. So we designed this as our separate unit that is specific to identifying and coordinating patients that require more virtual visits and the remote patient monitoring. So anyone that had those initial barriers to telehealth, or through our own internal healthcare assessments determined that we just needed more touches or more remote patient monitoring with them, we identified them for the program and are currently enrolling. So up to our engagement process, which is really sort of the core part of the discussion, we initially started the program out because we had identified already with our early adoption of telehealth, we'd identified a large population of individuals who had these barriers to telehealth. They were able to call us, they were able to text us, but when it came to doing virtual visits on their phone, they did not necessarily have that capacity, nor did they have the equipment. They didn't have a laptop or a tablet to do it as an alternative. So we initially started out with a text campaign saying, hey, we identified you that you have barriers to telehealth. We now have a new program where we can send you the equipment such that you can perform telehealth with us. Please let us know your interest. So one would think that if you sent that text out to 1,000 patients, that maybe 600 to 700 of them would respond, yes, I'm interested. Our initial response was, I think, 20, 25. It was a very sad and low number. And I think that speaks to some of what the previous presenter was talking about, and one, that trust factor, not understanding, and also the language barrier. So we did have to translate that message in English and in Spanish, and be careful of the Spanish translation. So we had to figure out different ways to get patients engaged. So once we got through the multiple lists, we determined that texting, in order to try to inform them of the program as well as get them engaged in the program, was not going to work. So we actually started a manual outbound call process, where there's an outreach to the patient. There's a discussion that they will refer to the program, some description of what the program is and what the benefits are, and what they would have access to. And even that did not result in as much response as we wanted to. So we are currently now at a process where really we've determined that that initial engagement really has to start at the practitioner. So whether or not it is a primary care on the physical side or a psychiatrist, psychologist on the behavioral health side, that's where the conversation really needs to start with the true engagement. So once that engagement happens, then there is a referral to the program, and we conduct our initial outreach. And in that initial outreach, the script really is speaking of contact, after the practitioner has already informed the member of the program, and then begins to explain what the program is, what the benefits are, what the expectations are as far as the kit and receiving the information. Once the kit is deployed and sent to the patient, we do a second outreach to confirm. So we know that the kit has been delivered. We use FedEx and UPS for the delivery, the deployment. So we know, we get a notification, but we still call to say, hey, we're just confirming that you received the kit. We're confirming that to this point, all the expectations have been met, and to sort of prepare them for a sort of a third call, which is the actual welcome call. So during that welcome call, this is done by a clinical person who walks them through the completing the setup of the kit, sort of taking some of the biometrics for the first time. So how to properly apply the blood pressure cuff, how to properly apply the pulse oximeter and the thermometer, how to properly mount the weight scale, as well as testing some of the survey questions on the tablet. And then during that welcome call is when we actually conduct the first virtual visit, so that there can be a direct connect from our case manager's portal on our side into the patient's tablet for that virtual visit. And then just as important are the ongoing outreach. So again, a point that was brought up in the previous presentation is the ongoing, I guess, activation versus engagement. So we have patients, for example, that the kit itself is actually, I'm going to call it nicely, it can be pretty annoying when it comes to reminding you of it's time for your biometric or it's time for your survey, which is a good thing. But somehow we still have patients that have the ability to completely ignore that or cancel it out. So you get 3 or 4 days without a blood pressure, or 3 or 4 days without the responses to the PHQ-9. So we've learned that we have to have continuous outreach to follow up, sort of asking, hey, not only do I see that 4 days ago you took a blood pressure that was a little elevated, but you haven't taken it since then. What are some of the barriers to that? What are some of your concerns? And of course, the things that we learn are that people are sometimes activated and engaged and taking care of themselves, but often get to the point where they say, okay, well, it's just too much. I just took my blood pressure yesterday. How different could it be today? And so that's where we have the opportunity to do education and explain, well, the reason that we put you on this program or offering this program to you is because we're concerned about you being able to maintain your blood pressure or your mental status, as an example. So in short, we have learned some lessons. As far as engagement, that consistent outreach is key. We have gotten our program down to where we've actually now removed the texting component. So there was a couple times that we would text people information, hey, expect your kit today, or we're going to call tomorrow. And we found that those did more harm than helped us, so we removed them. But we know that there's at least a minimum of 3 outreach events that has to happen to really engage the patient. Even with that, we have to provide ongoing education to our providers. What has happened before is that a provider has a conversation with a patient. The patient nodded, most likely in that visit, completely forgot that they were being referred to this program. When we reach out, the patient vaguely remembers, but then ends up calling the provider back saying, hey, Dr. Benbibre, is it really true that you referred me to this program and they're going to send me a kit? So we had to educate the providers to be prepared for that ongoing conversation as well. The other point is that once you get them engaged, you can't really let off of the engagement and the outreach in order to have ongoing application and activation. We've seen that we have to have consistent ongoing outreach, whether those are phone calls or sometimes we'll just do a random virtual visit with the client if they can answer. We'll talk them through and encourage them, give them encouragement if they have been doing the biometrics and answering the surveys, or help them figure out any solutions to any barriers. Specific to our program, it's been great in that we've been able to monitor and provide remote patient monitoring and expand our virtual visits with our patients. However, we do find that it still requires some engagement and ongoing outreach in order to keep those patients activated. Hopefully, if there are any questions, I'd love to answer them. And if not, I appreciate the opportunity to present today.
Thank you so much, Mr. King, for your presentation. I thought it was such a fantastic tie-in of how you were able to get the program up and running, and the lessons you learned throughout the process was really informative. I'm just letting a couple minutes go through just so folks can put some questions in the chat. And I do see one already, actually, from Howard Rubin from Community Health Centers of Pinellas, and he would like to know, how is the information obtained through the Vivify system? Is it integrated into the EHR?
Great question. So no, right now it's not integrated. So one of the pitfalls that we have had here at Banyan regarding our other engagement tools is that unfortunately we're using two separate EMRs, one for primary care and one for behavioral health. So the integration component got a little difficult because Vivify doesn't necessarily know which system to send or pull information to. So what happens today is that our practitioners that use the Vivify virtual visit, they're doing entry into the prospective EMR just as if they were using any other telehealth tool.
Fantastic. Thank you for that. I'm going to go ahead and try to also unmute the line, see if anyone else would like to ask any other sort of questions.
I do have a question. Great presentation, by the way. This was great. What happens with the maintenance of these devices? Is that Banyan's responsibility, or does Vivify help with keeping up with, I don't know, updates or calibration?
Yeah, great question. So yes, so Vivify. So the arrangement with Vivify, and this is their standard arrangement, is that Banyan has purchased the kits. And in that purchase, it includes sort of an ongoing maintenance, upkeep, update. And in fact, Vivify provides the deployment actually as well. So kits are deployed from a Vivify location when they are sent back. And right now we're running about 30 to 60 days per patient. So when their period is done, the kit goes back to the Vivify location where it is updated, cleaned, whatever their process is to prepare it to go back out again. So again, that was one of the points the things that we pointed out to the FCC is that, if we had purchased 200 laptops and we were trying to send them out to patients, we would not have the capacity to service them or, clean them or deploy them or pick them up. So we were fortunate to get the partnership with Vivify.
Thank you.
Absolutely.
Great. So I'm currently not seeing any other questions within the chat or any hands raised at this time, but I just want to again thank you so much for sharing your insights in your presentation this afternoon on your intensive telehealth and remote patient monitoring program. I think you gave folks a lot of food for thought as they're thinking about other ways for them to also apply for additional grant opportunities to try and implement something very similar in these times. It's very key to have our patients engage, even if it's in a virtual kind of remote concept. So thank you so much for your presentation.
Great, thank you for having me.
Fantastic. So now I will pass the floor to Harut Kasai, who will talk to us a little bit more about our UDS ECQM updates for 2021. So Harut, please take it away.
Hey, good afternoon, everyone. So at the last meeting, we had reviewed the new measures for 2020, and we had also touched upon the approved UDS changes for 2021. And this slide was included in your last package, and we had mentioned that these 13 clinical measures were going to be aligning with the most recent ECQMs. And so what I did is I kind of went in more detail on each of these, checked the ECQM page for anything that's significant. Now, a lot of the changes are just in like language, clarifying the language, and things like that. But there were a few that are going to have an effect on the clinical measures and how we are measuring them right now. So if you look at the next slide, the first one that I found a change in, and I think it was also mentioned in the HRSA Today with McRae webinar yesterday, is the one for cervical cancer. So if you can move to the next slide. Okay, so with the cervical cancer, if you recall previously, for age 30 to 64, it was looking for a PAP along with HPV. So either they would have a PAP, and that was okay, it would count for 3 years, or if they had a PAP with an HPV together, then it would be okay for 5 years. So now they've taken that requirement of having the two together away. So the updated measure description is basically percentage of women 21 to 64 years of age who are screened for cervical cancer using either of the following criteria. Women aged 21 to 64 who had a cervical cytology performed within the last 3 years, in other words, a pap smear, or women aged 30 to 64 who had a cervical human papillomavirus testing, the HPV testing performed within the last 5 years. So it no longer requires the co-testing of PAP and HPV in that 30 to 64 year range to count for the past for having screening to last for 5 years. Okay, so that's a pretty big change. So if they only had 30 to 64 and only had a HPV test, it will still count for a PAP screening, and it will be good for 5 years. Okay. If you go to the next slide, the second one that I found of significance is with the tobacco use screening and cessation intervention. So what you see on this page is basically with regards to how the ECQM states it. In the ECQM, it looks at 3 subpopulations. You know, the first is, you know, those that were for patients that were screened for tobacco within the last 24 months, it used to be. So patients aged 18 and above who were screened for tobacco. And then the second subpopulation is of those that were screened and tested intervention. And then the third subgroup is putting those two together. So looking at patients 18 and over who were screened for tobacco, and if they were found to be a tobacco user, was their cessation intervention. And basically for UDS, it just looks at that third combined group. So the major change in this is that it used to look at tobacco screening having been done within the last 24 months. The new update to the ECQM is now it's going to be looking for tobacco screening in the last 12 months. So that's pretty big. If we move to the second slide, it kind of describes the 3 groups, and the one that I highlighted in blue is basically the one that's used for UDS. So percentage of patients aged 18 years and older who are screened for tobacco use 1 or more times within the last 12 months, and who received tobacco cessation if identified as a tobacco user. So again, the time frame for looking if a patient had a tobacco use screening has been reduced from 24 months, within the 24 months to within 12 months. Okay. Next, there's a couple items that are not as major, but it does involve some change. And so the first one is for the depression, screening for depression and follow-up plan. And so the two ones that I thought were more significant, I've listed all of them, but they've revised the denominator exclusion logic to reflect that any patient with a current or historical diagnosis of bipolar disorder or depression should be excluded from the measure. Previously, it said active diagnosis, right? So now it's looking at current or historical diagnosis of bipolar disorder or depression as an exclusion factor. The second more significant one that I thought was they've removed suicide risk assessment and additional evaluation or assessment for depression as appropriate follow-up options to meet the numerator. So that's also a change that has occurred with the current version of this electronic clinical quality measure that UDS is now aligning with. Okay. There's a couple other small things, but I thought those were the two kind of more significant ones. And then finally, the other thing that I saw, which was a little bit more of a clarification in an exclusion factor that is used by several measures. It was an exclusion factor for long-term illness, right? So now it's now clarified that when it says long-term illness, it means a long-term illness with at least 90 consecutive days. So at least 90 consecutive days of long-term illness is what would be applicable to exclude a patient from the measures that are listed below: breast cancer screening, colorectal cancer screening, controlling high blood pressure, and also the diabetes HbA1c poor control measure. Okay, so those are the ones that really kind of stood out to me that may have some effect. Again, the first two being the more important ones, the cervical cancer and the tobacco use, because that might change some of our potentially some of the workflow. Definitely with tobacco, we want to make sure that we're doing it at least within the last 12 months rather than 24 months. Okay, so and then finally, I just wanted to mention a couple of changes that were announced in the HRSA call yesterday regarding the quality improvement awards. And I know they've been saying that they are going to be changing how they do the quality improvement awards and had not really given us any detail. In this last call that took place a couple of days ago, they have confirmed that quality improvement awards will not be given out this year. So what they are doing is they're going to be shifting to a more prospective method rather than a retrospective, let's give you something for what you did in the past. They're trying to shift to a more prospective method of encouraging and supporting community health centers with quality improvement activities or initiatives. And they've told us that this year their focus will be on optimizing virtual care, which kind of ties in with everything that we've spoken about earlier. So we don't have any more details. They didn't really provide any more details, but more information will be forthcoming very shortly is what we've been told. So just want to make sure that everybody's clear that the way that they're incentivizing for quality is definitely changing, and there will not be any QIA awards the way that we've been seeing them for the past several years for this coming year. Okay, and that's all that I have for you for today. If you have any questions, I'd be happy to entertain them.
Thank you so much, Haru. I'm taking a look at the chat right now just to see if there's any other questions that may have come through. And I'm currently not seeing any at this time, but thank you for your fantastic presentation. I think it's really insightful for us to be in the know of what's going on with those QIAs, those quality improvement awards, and hearing that they're going to be focused more so on that virtual care component makes a lot of other discussions that we have in these groups so important. So thank you so much for sharing your key insights.
Well, thank you.
Okay, awesome. So then what we're going to do really quickly is just take a quick look at our QTECH strategic planning review. So within our different clinical engagement forums that we have, we try to do some strategic planning to get a better pulse on what our focus areas should be within the QTECH committee meeting, as well as other clinical initiatives at your health centers to make sure that we're aligned in our content for our clinical engagement strategy meeting. So with this one, we can see that we had a ranking of 4.38 on average for how we did in 2020 for the QTECH committee, which is fantastic. One of the questions we actually asked was in reference to different areas of opportunity for us to focus on or continue focusing on. So as you can see here, preventing and managing diabetes was at the very top as listed as a first choice option, followed by ending the HIV epidemic, with that first option being very clear there. And then of course, some other additional focus areas with improving cardiovascular health, which is really insightful. As we proceed to the next slide, what we're going to look at here is some other additional importance areas or focus areas that your health center had in reference to other clinical areas, one of which being up top is preventative cancer screening. There's been quite a few discussions going on, definitely in terms of last year, of how patients can come in and how we can get them to come in to provide some of those key preventative cancer services, knowing that most of those cannot be done in the virtual standpoint. So finding out ways to bring them in to do their cervical, breast cancer, or even to get them scheduled for the colorectal cancer screenings as well. So then in addition to that, another focus area that was chosen as first choice most often was social determinants of health, which that's a key focus within the QTECH grant. So definitely more discussions to come from that. We proceed to the next slide. Here, what we're looking at is, again, another ranking in terms of a Likert scale. So from not interested in this case is actually the orange, but most important to focus is that darker blue color. So in terms of areas for the QTECH committee to continue focus on in 2021, we can see here that the data analysis, so moving the needle on quality outcomes, continues to be a huge focus area. So for that exact reason, we have our opportunities with Harut to talk more about those ECQMs and key changes to those items that might impact clinical workflows at health centers. In addition to that, we do see other key focus areas like data integration, finding ways to further the discussion on how data from different systems, similar to how we mentioned today, can all kind of integrate or at least try to integrate in a certain way so that key information is accessible in terms of that patient data. Other focus areas include social risk factor interventions, which again ties into those discussions on social determinants of health and even telehealth implementation. So all of those topics will continue to be really key focus areas for our QTECH committee as we proceed in 2021. Perfect. So then with that, I want to say again, thank you for participating in the annual strategic planning. And without further ado, I'd like to pass it to QTECH Literacy, our HIV program coordinator, who will teach us a little bit more about National STD Awareness Month. So QTECH, the floor is yours.
Sure. Thank you. Hello, everyone. It's a pleasure to converse with you and just share a little bit. So this is going to be a quick plug regarding what's going on in the world of STD. As stated before, April is National STD Awareness Month. STDs are sometimes considered not a priority among many people. However, they create a huge burden for a huge part of our population. And I know for a fact that a lot of our community health centers are constantly helping to meet the needs of those that are affected. So I just wanted to say thank you. So first I wanted to start with the scope of the problem. According to CDC's 2018 data, which is the most recent available data, 1 in 5 people in the United States has an STD. And that was approximately 68 million people by the end of 2018. Of that, I'm sorry, yeah, 68 million people by the end of 2018. And of that 68 million people, 26 million of those were new infections. And almost half of those new infections were among youth age 15 to 25. So if you go to the next slide, please, thank you. To advance, right? So instead of going deeper into like race and gender breakdown of who's affected, I wanted to bring some perspective in terms of the financial burden that that has afflicted many in regards to STD. So it is a heavy one. At the end of 2018, about $16 million was spent on direct medical costs associated with STDs. So that could be federally funded programs, some out of pocket, and some associated with insurance. Nevertheless, 16 billion with a B is a large sum of money that could probably be focused elsewhere. But women and youth aged 15 to 24 years of age each accounted for about a quarter or 25% of the total cost of direct medical care. 1.1 billion of those direct medical costs was attributed to chlamydia, gonorrhea, and syphilis, which are very common and preventable infections. HIV costs total was approximately 13.7 billion US dollars. And interestingly, if you could please slide to the next, move to the next slide as well. Interestingly, although it was not highlighted on the previous slide, nearly 75% of the 2.2 billion in non-HIV related STD medical cost was attributed to the care provided to women. So that's not really shocking, but still at the same time, it's quite interesting. The Ending the HIV Epidemic, a plan for America, identified 4 key strategies: diagnose new cases of HIV, treat people living with HIV as soon as possible, prevent new case transmission, and respond to outbreaks of HIV. HCN is excited to work with our partners and health centers to address HIV and other STDs. We have already started some of the conversations around the ending the HIV epidemic, and we've taken some actions through improving some of our electronic medical records functionality, and also creating an environment where our members can share ideas and also some best practices. I'm looking forward to conversing with as many of you as possible. If you are interested, you can contact me through Stephanie or through directly through HCN's Quality Initiatives program. So again, my goal today was just to bring a little bit of awareness around the situation of HIV, and to thank all of you guys that are doing so much work regarding STDs, especially HIV in the region. So thank you very much, and have a wonderful rest of the afternoon. I'm going to pass back to Stephanie.
Fantastic. Thank you so much, Quasi. This information is really key, and it helps just to educate on different key health initiatives that come up or that are coming up in time. So it's good to get the word out and see if you can engage your social media folks at your health center or any involved in marketing, so that you can get some awareness campaigns out there in reference to these. So great work on that. Just some other announcements really quickly before we leave you all today. We have our COVID-19 session number 14 that is actually upcoming. It's next week, Wednesday. So that's an opportunity for us to continue the conversation on vaccine rollout within health center space, and hearing from other health center experiences with that vaccine dissemination, and coaching our patients and communities through becoming vaccine confident. So we're very excited to announce that. And then I think on the next slide, we have just a reference to April 7th being World Health Day. So it is another opportunity to do some research on what is out there to honor that World Health Day in April. And then I think this may be our last one in reference to Clinical Leaders Workshop. So we're really excited to host the spring session of our joint Alliance Chicago and Health Choice Network Clinical Leaders Workshop opportunity. It is being hosted virtually for 3 days, as you can see listed here. Registration is now open, so we're excited to welcome you all in this facilitated peer learning opportunity amongst other clinical leaders and chief medical officers. If this is something you're interested in or want to get the word out as well to other folks at your organization. So then with that, we want to leave you and say thank you so much for joining us for March's QTECH committee meeting. We're really excited to continue the Learning Collaborative for Electronic Patient Engagement with Dr. Boss, as we did to date. And with that, let's have our calendars marked for April 22nd. I'm looking forward to seeing you all, and thank you for joining us today, and have an amazing rest of your day. Thank you.